Well, welcome everyone to today's Health Professions Educator Series, Health System Science Open Forum, which is a lot to say, but welcome. Today, we are lucky to have Dr. Andrew Moore, Assistant Program Director for Emergency Medicine, Assistant Professor for the Department of Emergency Medicine and the Department of Health Systems and Implementation Science, physician within emergency medicine, and the Emergency Medicine Health System Science Clinical Champion. And he is here today to present on the topic of comparative health systems. What can we learn from other nations? Dr. Moore says that you are welcome to ask questions as he goes. Feel free to post in the chat or speak up if you have a question or comment. So on that note, I will hand things over to Dr. Moore.
Fantastic. Thank you for the introduction, Mariah. So welcome everyone. Thanks for taking some of your lunch hour to kind of walk through this lecture with me. I am not a health policy trained clinician. My fellowship was actually in research, but this is something that I've always been passionate about. And so when the opportunity to become a clinical champion for health system sciences presented itself, I kind of ran with comparative health systems, health policy, and health economics. And so this is the genesis for this lecture. This lecture has morphed over many forms. It's really a fool's errand to try to trim down 600 pages of text into a 1-hour lecture. So I've morphed and modified how we talk about comparative health systems. It's a project that we do with our M2 students. We actually have them break out and study healthcare delivery in a foreign country, and then present it back to their peers for near peer education. And hopefully they learn a thing or two. And this is kind of a wrap up of some of the ways that we can utilize healthcare delivery systems or approaches to healthcare delivery from other countries to increase the healthcare outcomes in the United States and also decrease cost. So disclosures. So these are my views. They don't reflect the views of Carilion Clinic or Virginia Tech Carilion School of Medicine. I also have research funded by Philips and BioTel. So if I tell you that the answer to solving all of America's healthcare problems is to put wearable cardiac telemetry on people, then you know that this is a biased presentation. It is most definitely not the answer, but that's what they pay me to do with my research time. I have to give a special thanks to Dr. Lee Lehrman, Dean of VTC School of Medicine, for inviting me to be part of the health systems team and making health system sciences one of the pillars of our education for our medical students. Also, can't go any further without thanking Dr. Kelly Whitmer, one of the clinical champions for health system sciences. Dr. Whitmer was going to actually do this presentation with me, but as you know, it's very difficult to make a room dark for Zoom, and we could not get the room quite dark enough for him to participate. Yes, that was a radiology joke. Also would like to thank Drs. Natalie Karp and Dr. Cynthia Morrow, who have been essential in terms of developing our M2 curriculum, and also the rest of my clinical champions cohort and all the fine folks at Teach who are putting this on today. So thank you to all of you. To many of you, this wheel may look familiar. This is our health system sciences wheel. This is our foundational approach to the way that healthcare is delivered in the US, thinking about how we want to approach healthcare and all of the different elements that go into it. And this is the foundation for our health systems curriculum throughout the medical school. So our objectives today are heavy. We're going to describe drivers of cost in the United States healthcare delivery system. We're going to review OECD countries' approaches to healthcare delivery, and we're going to devise solutions to control costs and increase health outcomes in the United States. And in order to do that, we're going to need to start off by checking the state of US healthcare. And unfortunately, things are dire. This is from Kaiser Health News. You can see that there are higher performing countries up here: Norway, the Netherlands, Australia, and way down here at the bottom in the lower performing, that's the United States. And unfortunately, healthcare delivery is not golf, which means we are not doing a very good job. This is another way to kind of look at the fact that we are not doing a good job. Our overall ranking is number 11. Access to care, administrative efficiency, equity, and healthcare outcomes all put us at the bottom of the table in terms of how we deliver healthcare to our citizens. And not only do we deliver poor healthcare, but we do it at a very, very high cost. So these are 2021 numbers, and you can see that we spend per capita approximately $12,318 for each citizen, and relative to other countries that are of also high earning countries, we are almost double the closest, and we're definitely double the average of 5,829. And just to further drive home the fact that we are outliers, anyone who appreciates a good trend line here can see that when you compare the GDP per capita, which we're right here at about 70,000, versus the healthcare spending per capita, we are outliers from the mean. So why are costs so high? It's complicated. We're going to talk a little bit about that, and then we're going to talk about some solutions that hopefully can help us reduce costs and increase healthcare outcomes. So one of the reasons that healthcare is so expensive is because American healthcare is big business. This is a tenet that you have to accept to want to change American healthcare. If it wasn't big business, we wouldn't see Jim Cramer here on CNBC telling us to go ahead and buy HCA and United Healthcare. And maybe even a little more relevant is United Health Group's earnings statement. This is from October 13th of 2023. United Healthcare is the largest private insurer in the US. Their revenues for this quarter were $92.4 billion and grew 14% year over year. Their cash flow is $6.9 billion, and their earnings are quite high. In fact, United Health Group is number 5 on the Fortune 500 list with a market capitalization of almost $500 billion. That puts them as the 14th largest company in the entire world and the 5th largest in the US. So just for those of you who didn't go to business school, the purpose of a publicly traded company is to maximize profits for its shareholders. So in my opinion, for-profit healthcare is one of the major drivers of cost. So we have some other areas where we can improve US healthcare delivery. One is administrative costs. 2 is lack of uniform electronic health records. I feel this acutely every shift I have in the emergency department. 3 is pharmaceutical costs. 4 is how we've found our access to care in the US. And then 5 is medicine as a business. So we'll revisit some of those slides that we just looked at. So what can we learn from other countries? As I said earlier, it's a fool's errand to try to outline how every country approaches healthcare. It's rather droll, and it would definitely drag on for greater than 1 hour. So I can't do that. But what we can do is we can highlight some countries that are doing things maybe a little bit better than us, or some countries that we've already learned from. So let's start with our friendly neighbors to the north. Oh, Canada, their blood's as thick as maple syrup. What have they given us? Well, they gave us Medicare. So Medicare and Medicaid, which we passed into law in 1965, just a definition, Medicare covers all Americans greater than 65 years of age or those with permanent disability, so such as end-stage renal disease requiring dialysis. And then Medicaid covers the more financially destitute. This is one of the hallmarks of America saying healthcare is not really a right, but we should give some sort of access to it. So Medicare and Medicaid were both modeled after the Canadian Medicare system. We liked it so much, we stole their name as well. And this was actually pioneered in Saskatchewan in the 1940s. So it's not often we look to Saskatchewan to be leaders in anything, but they did bring us Medicare and Medicaid. So what it is, it's a single payer. That's the government is the payer, and it pays primarily private nonprofit hospitals in Canada. In the US, it pays all hospitals. In the US, we have a blend of private for-profit and also private nonprofit hospitals, which religious hospitals would fall into that category as well. Medicare and Medicaid provide good care at a low overhead. Approximately 2 to 3% of total costs are spent on overhead, whereas estimated overhead on private insurance is anywhere up to 17%. And some estimations actually say up to 30 cents per dollar spent on US healthcare is spent on administrative costs. So what does that look like for me in the emergency department? It looks like the employment of an internal physician advisor. So we have to pay non-clinical physicians to argue with insurance companies to pay us for the care that we provide. That is the system that we currently live in, unfortunately. So thank you, Canada, for Medicare and Medicaid. I know everyone over 65 enjoys it quite nicely. I'm going to throw my in-laws under the bus here, who both waited to get their hips replaced until they were Medicare eligible. We've also taken something from the United Kingdom. The United Kingdom has the national health system, the NHS. It's the largest single payer and socialized healthcare system in the world. It has a lot of shortcomings, and anyone who follows MedEd or FOMED on Twitter, I'm sure has seen the rumbling and grumbling about the pay that their physicians receive and their inability to fill positions as a result of Brexit and other choices that they've made. But despite its shortcomings, it's provided egalitarian care to the citizens of Britain for over 70 years. We have something very, very similar. The Veterans Health Administration is actually pretty much a straight riff on the NHS. It serves lifelong care to honorably discharged service members. It is a socialized healthcare system. So what that means is that the government owns the buildings. The government employs all of the employees, and all of the healthcare is covered. It is very similar to NHS. One thing that the Veterans Health Administration is kind of whipping boy for a lot of different things. It actually provides very efficient care and turned things around in the 2000s, so much so that the demand became quite high. So they are doing a very nice job, and I can speak from experience having worked at the Portland VAMC, that it really is a unique experience as a physician to work there, because when there are no barriers to care, it's great to have a patient who might present with, say, a cellulitis on their arm, be able to go home, take antibiotics, and come in the next day for a following checkup, as opposed to a much more costly observation admission or something that we would use in a different system. So this definitely provides a means for cutting costs by making care more accessible. One thing that the VA does very, very well, it's maybe not the most user-friendly, but they actually have a national electronic health record called CPRS. And so any patient who interacts with the VA medical system anywhere in the country has notes that are generated and accessible from anywhere else. And so if you have a veteran visiting another state, you can see all of their healthcare interactions and all of their medical problems, which provides much more efficient care. That, unfortunately, is not the case in the private setting. And here you can see two different depictions of myself. On my left here, you can see me on a normal shift when a patient checks in from Lewis Gale and says, I just left, they did nothing for me, because I can't see what they've done for their workup. So this is one of the major drivers of inefficiency, at least in my role as an emergency medicine physician. Over here on the right, this is me when I worked in Portland, Oregon, because the city of Portland got together and every hospital in the city opted to join Epic. And Epic is a brand name of a EHR provider, but one thing that they have is something called Care Everywhere. And so if a patient opts in, you can actually see all of their interactions with the healthcare system. So oftentimes I would have this exact same patient presentation in Portland, and a patient would show up and say, maybe, I had really bad chest pain and I went to Good Sam in downtown and they really didn't do anything for me. And I could pull up their medical record and see that the patient had an EKG, a chest x-ray, serial troponins, and even a CT angiogram to rule out a pulmonary embolism, which is, roughly a $20,000 workup, and I could spare them from any more testing and just do a lot of counseling. So a EHR accessible to everyone in the country is one way that we could potentially reduce redundant testing, as patients are known to shop around for second opinions or go to a different hospital if they're dissatisfied with their care. So who does this really, really well? Well, the country of Taiwan actually does. So Taiwan were late adopters of a national medical system. They actually didn't adopt a nationwide medical system until the 1990s. And one of the areas that they have been most effective is being leaders in a national EHR. So what happens in Taiwan is every patient, it also has compulsory enrollment, which we'll talk about later, but every citizen or patient carries a card with them, and that card actually has their demographics and their insurance billing information on it. And when it's plugged into one of their terminals, it will show you any medical interventions that need to be logged. It'll allow you to file for immediate reimbursements, and it will allow you to access their online medical records for the most recent 6 visits. So it gives you access to MediCloud, which is all of the patient's prior diagnoses, their prior allergies, vaccinations, and their 6 most recent visits. It also accesses PharmaCloud, which is all of their prescription information. And then every patient has access to something called My Health Bank. So it's a cloud-based access to their entire medical record. So if the most recent 6 visits are insufficient for the physician to figure out what's going on, the patient has access to their entire medical history in the palm of their hand. Not very different from MyChart, which is what we use in Epic, except that it is on the national level. Whereas not every EHR in the US has that same interoperability. So what are we doing to address this? Well, we've actually started to improvise some solutions, and the 21st Century Cures Act came online about 1.5 years ago now. And what it did is it actually defined electronic health record interoperability, addressed health information technology certification requirements, and prohibited information blocking. So it's created a common language for different computer systems that are used in the US to create basically a back channel for them to communicate. We are starting to see that. I will occasionally now see reports coming through from our colleagues at Lewis Gale across town. Unfortunately, there's no formatting and it's just straight text, which is very difficult to read. But we are starting to improvise and implement solutions to make this more user-friendly and hopefully reduce redundant testing, which will drive down costs. Pharmaceuticals, they're expensive. They are actually one of the major drivers of cost in the US healthcare system. We spend approximately $500 billion per year on pharmaceuticals. It's 17% of entire US healthcare spending. Per capita, we spend $1,400 on medications, which is twice the average of European nations. This spend is secondary to high costs of medications, not high use. So compared to some other countries, we're not necessarily the highest user of pharmaceutical medications. This is a factoid that I found rather striking, and that is that 90% of prescriptions written in the US are for generic drugs, but they only account for 26% of drug costs. So it's those name brand medications that are really starting to drive up cost. One of the reasons that this happens, and there's a multitude of reasons, part of it is our patent system. We provide 20 years of essentially a monopoly on a new medication, and we don't have any price controls. The other is that we have very fragmented pharmacy benefit manager programs, which gives them less negotiation power as, say, something like a national formulary would. The VA healthcare system is a really nice example of a healthcare system that implements a national formulary system. So if you want to deviate from what medications are available in terms of treating your patients, you have to actually get approval and go outside of that. And they choose medications that have a good profile effect and also have been shown to be cost effective. So there's a couple different countries in Europe that are doing this much, much better than we are. Norway is one of them. And I know Norway is kind of hard to compare because it's a much smaller nation. They have a much lower populace. They're much more homogenous. But they have some tools that they've brought in terms of how they set prices that could effectively be used in the United States. And so how they do that is, well, first off, they spend $400 per capita. So they spend $1,000 less per year than the United States spends on medications. The way that they break that out is their national insurance pays about 75% and consumers are left to pay 25% of the costs. They do a nice thing though. They cap certain medications at $275 annually and $200 annually. So that 25% of the cost will not become exorbitant like it might in the United States, where, for example, a patient on a $10,000 per month chemotherapy might be stuck paying $2,000 per month out of pocket for their medication. So they have a couple systems in place to make sure that medications are affordable. And so they have the Norwegian Medicine Agency. And what this agency actually does is authorizes the marketing, monitors adverse events, and sets maximum prices following EU regulations. And they also monitor cost effectiveness and consider that as part of the price. Manufacturers have to apply for a maximum pharmacy purchase price that will then be agreed upon by the Norwegian Medicine Agency. And those agreements are valid for 5 years and have to be reapplied for every 5 years. In contrast to the US, there is no such system. We say, thank you for developing this fine medication. We will pay you whatever you want. They also have implemented something called a health technologies assessment, which basically means that any new medication, any new device, or anything that wants to come onto the market has to be evaluated based on overall benefit, the resource utilization, and the severity of the condition it treats before they will even consider adding it to the national formulary. They also have an informal cost cap. So what happens is the Norwegian Medicine Association will look at the QALYs, or quality active life years, similar to what the UK and Australia do. And they say, if this medication provides you 1 year of good quality life, we'll pay up to $31,500 for that medication. So they've kind of put a cap on things in terms of treating major illnesses. They will relax it up to $90,000 if it's a life-threatening illness, but overall they try to contain costs through this way. And it's very similar to the approach that England and Australia also use. Whereas in the United States, we kind of say, hey, we'll pay whatever to see how long we can stay alive. Germany is another European country that does a good job controlling costs. I chose them as well as Norway. Norway are kind of underutilizers of medication. They very much fit their stoic stereotype of not wanting to take medications. Germany, the German populace, is actually quite a large consumer of medications. So I thought it'd be interesting to approach how they can cost contain medications. So they spend about $780 per capita, or half of what we spend in the US. They have an interesting price regulation mechanism, and that is that for the first 12 months, a pharmaceutical company can sell a new medication for any price at all that they want. What will happen then is the Institute for Quality and Efficiency in Healthcare determines if medications is comparable to other medications on the market. And if it is, so let's use, for example, something like Crestor or rosuvastatin versus Lipitor or atorvastatin. That new medication comes on the market and they say, oh, it basically does the same thing. Then the Institute for Quality and Efficiency actually has the ability to set an internal price and say, this is what we will reimburse you. Thank you, pharmaceutical company, take it or leave it. Now, there's a little caveat that if an additional benefit is identified, what will happen then is that the pharmaceutical company and the Federal Association of Sickness Funds, that's the group of 105 nonprofit insurance companies that insure the vast majority of Germans, will get together and negotiate a price. If they're unable to do that, it actually goes to legal arbitration. And then the sickness funds, which are the insurance companies, actually get 3 separate rebates from the pharmaceutical companies to help drive down medication prices. I found this really interesting. I wonder how it would play in America. My suspicion is not very well, but they have pretty intense physician regulation. So they have a federal joint commission that provides guidelines for appropriate treatment, and it can actually impose fines on physicians who are not complying with appropriate treatment or using appropriate medications. And they go so far as to choose not to reimburse medications that might be used off-label. So for everybody who prescribed ivermectin during COVID, just be thankful you're not German. So what have we done in the US that could potentially be a solution here? Well, in 2022, we passed the Inflation Reduction Act. This is the first time that we have provided Medicare, Medicaid with the ability to negotiate with pharmaceutical companies to lower cost. So specifically, we gave this ability to Medicare, and the goal here was to lower costs for Medicare Part D. Medicare Part D is the medication aspect of Medicare. There's 4 different elements to it. They chose 10 medications based on the overall cost between June 1st, 2022 and May 31st, 2023. These 10 medications that they've selected actually accounted for $50.5 billion in total medication costs over that 1-year time frame. In fact, these 10 medications alone accounted for 20% of all Medicare Part D funding on medications. So this is a huge target for lowering costs of care. And obviously you can see that many of these are novel anticoagulants such as Eliquis or Xarelto. They're newer diabetes medications such as Jardiance, Januvia, or they're things like Enbrel, Humira, which is going to be a monoclonal antibody used for immune issues. And then also we have our friends insulin down here, which has become excessively expensive. So hopefully, it's to be seen what will come of the Inflation Reduction Act and the ability to negotiate for prices. There are multiple lawsuits being levied by pharmaceutical companies back to the federal government to try to block this. But this is, potentially huge in terms of caring for our patients and also lowering costs. It always crushes my soul just a little bit when I have to prescribe Eliquis to somebody with a new DVT, and I also have to hand them a drug coupon because their out-of-pocket expenses, even when they're covered by Medicare, are $1,500 to $1,800 per month on a medication that they're going to be on for at least 3 months. So definitely a great opportunity to lower costs. And again, this is happening in real time, so we'll just have to see how it all ends up playing out. All right. Access to care. This is something that kind of falls near and dear to my heart because I feel this every day when I go to work. So we, again, kind of revisiting the United States and our regard for healthcare, have said that healthcare is not a human right. We're one of the only developed nations who have not come out and stated healthcare is a human right. We kind of danced around the issue and we've created these stopgap measures that make it seem like maybe some people feel that way, right? So Medicare, Medicaid, things like CHIP that insure children, and EMTALA. So EMTALA is the Emergency Medicine Transfer and Active Labor Act. It was passed in 1986. It was 4 pages tacked on to a 229-page Consolidated Omnibus Reconciliation Act, so a budget act of 1986. It was passed because there was outrage in the lay community about patients being dumped on the side of the street if they had an inability to pay. And so essentially what was happening is Granny would go to a hospital with altered mental status. They'd say, "Oh, I'm so sorry, your private physician is not part of this group. And by the way, you're uninsured. There's a county hospital 20 miles down the road that would love to take care of you." And hospitals were actually putting these confused grannies in their hospital gowns and sending them down the street in cabs where they would get dropped off in front of the hospital and just wander around aimlessly. And probably more alarming for the general public is that the same thing was happening for patients in active labor. So patients would show up to hospitals in active labor. They would be triaged based on insurance and ability to pay and told to go down to the county hospital. And children were being born on the side of the road and mothers were dying. And Congress decided, nope, this is unacceptable. We're going to create something that will solve this problem. And they created it, but it's an unfunded mandate for care. So it's created access to care at the emergency department level, which for a multitude of reasons is some of the most expensive healthcare that we provide. And so part of that is facilities fees generated to keep the lights on. Part of it is real-time testing. Part of it is the training of emergency physicians to constantly be thinking about things that could take your life, and that usually results in larger workups. So we've done some things recently to try to improve access to care. The ACA, the Affordable Care Act, also known as Obamacare, was passed in 2010. And it actually had a mandate for care. So you were required by law to purchase insurance. And it lacked teeth in the sense that the penalty for not purchasing insurance was significantly lower than the fee to purchase insurance. So, for example, when the marketplace came online, if you were not offered insurance coverage by your employer, oftentimes it would run $1,000 per month just for health insurance coverage, and the tax penalty that you had to pay, I believe, was only $500 to $1,000. So many people just ate that cost as opposed to buying into the insurance coverage. It also gave rise to one of the more famous arguments in the Supreme Court, which was Anton Scalia's broccoli mandate, where he compared the required purchase of health insurance coverage to us forcing Americans to buy broccoli because it's healthy for them. So I think that, when we think about mandated insurance coverage, perhaps the personal liberties and free will that this country were founded on will unfortunately keep us from having government mandated insurance purchased. So let's visit a couple countries that do it a different way, though. So Germany, Netherlands, and Switzerland all have statutory, compulsory, and mandatory health insurance. Germany actually has one of the oldest insurance markets in the U.S., or in the world. And it's actually what the Clinton healthcare plan was essentially designed around. And it's very similar to what we do in the U.S., except that all 105 of the sickness funds in Germany are mandated to be nonprofit. United Healthcare would not be making 90 billion per quarter in Germany. So 87% of the population is covered by those 105 sickness funds. And what happens is if you make less than $65,000 US per year in Germany, you are automatically enrolled into the compulsory insurance program. You can choose any insurance company, and you can actually change up to 2 times a year. And what happens there is that the insurance companies will actually start to compete for the patient pool. So much like cell phone companies in America compete for a larger group of subscribers, all of the German insurance companies want a larger group of subscribers because that gives them more bargaining power within the sickness funds. They do have specialized schemes. So if you make over $65,000 US per year in Germany, you're actually allowed to purchase private insurance. And then they have specialized schemes for police, soldiers, and asylum seekers. The Netherlands also has a compulsory and statutory enrollment. It covers 99.8% of the population. This was a result of the Healthcare or Health Insurance Act of 2006. So I think one kind of common misnomer when we think about how care is delivered in foreign countries is that they're similar to England in that they have this healthcare system that's just been around forever, but that's really not the reality. You can see that many of the countries, including Netherlands, are kind of newer adopters to mandating health insurance. So 2006 is, not that far ahead of the ACA being passed in 2010 here in the US. So what will happen in the Netherlands is if you are not enrolled within 3 months, they actually charge you a fee of $440 US, and they repeat that bill every 3 months until you enroll in a plan. And if you just choose not to enroll, the tax office actually has the ability to choose a plan for you, enroll you in it, and start garnishing your wages so that you're part of the national healthcare plan. And then Switzerland in 1994 passed a federal health insurance law that created an individual mandate, very similar to Germany. They have 90 sickness funds. If you do not enroll there, they probably have the harshest penalties. If you choose not to enroll in mandated healthcare, they will withhold wages to pay your premiums, and they'll charge you up to a 50% penalty. So they are very serious about getting you enrolled in their mandated healthcare programs. All right. So healthcare is big business. And this personally is where I feel like we have the largest opportunity to cut costs, unfortunately, because the companies that make this money are so wealthy. It's an uphill battle that probably won't happen. So we talked about privately held or publicly traded companies already, and that their goal is to maximize profits for their shareholders. So you have the United Healthcares of the world, the Hospital Corporation of Americas of the world, that have stocks that Jim Cramer wants you to buy because they are highly successful. There's a whole nother realm of American healthcare that's probably happened over the past 15 years that has significantly driven up healthcare costs. Again, as everything, my lens into the healthcare world comes through the emergency department and emergency medicine. And anyone who lives in South Roanoke hears the constant hum of helicopters coming in to deliver patients from our very, very large catchment area. Probably, in my opinion, worse than the involvement of for-profit publicly traded companies in healthcare is the involvement of private equity firms. So private equity firms essentially find a company, find a way to maximize its profits, and then turn around and sell that company for financial gain. They've ruined many things in my lifetime, including J. Crew, and they are currently in the process of doing their best to ruin healthcare. So this is a headline from Intelligencer. Kaiser Health News, Vox also have long lists of articles about the insane costs of air ambulance flights. And this specifically is a story about a freelance journalist who fell and injured her back while skiing at Mammoth Mountain. Was told that she needed to be airlifted to a spine center, and that helicopter flight cost $86,000, of which her insurance company only covered $17,000. So she was on the hook for a $79,000 air ambulance bill. Status part is she had broke her back, so she was just laying on a stretcher staring at the ceiling. She didn't even get to look out the windows. So why are these so expensive? And the answer is private equity. So this is from the USC Schaefer and Brookings Institute. You can see as of 2017, the costs associated with air ambulance transport, and then who owns them. So if you look here, here's orange, which is municipal other. Here's dark gray, which is hospital. We would fall into the dark gray category with lifeguard. Medicare reimburses approximately $7,500 for a fee or for a life flight. KKR, which is a large private equity firm, and American Securities as well, you can see they charge up around $40,000 up to $50,000. So much so that the current average cost of a helicopter ambulance in the United States is running about $40,000. Or to put that in perspective, $4,000 more than the average person earns in the city of Roanoke per year. This is, so the last slide was highlighting costs, and this is highlighting who owns these companies. So you can see PHI Incorporated, American Securities, and KKR are all hedge firms or hedge funds, and they own approximately 75% of the helicopter air ambulance service in the US as of approximately 6 years ago. Why did they get into this field? So interestingly, the Airline Deregulation Act of 1978, which was designed to allow more competition in the patient transport space and has given rise to Allegiant Airlines, Spirit, Frontier, and all of the other low-cost carriers, included all 12 air ambulance services that existed in 1978. And because it was a federal law, it meant that no states could bargain with companies that provided air ambulance services to lower costs. So essentially, there was a loophole allowing companies to charge whatever they wanted for air ambulance care. So we've come up with a solution here, and that's the No Surprises Act of 2022. I'm not going to address other countries' approaches to for-profit healthcare because we're really the only country that's afflicted with this level of for-profit healthcare. But the US solution was a No Surprises Act of 2022. And again, similar to passage of EMTALA in 1986, enough of these articles about people being stuck with $80,000 air ambulance bills or surprise bills when they went to an ER that was out of town, which again, you can't control, or even worse, when patients went to a hospital that was in their insurance network only to receive a surprise medical bill from an emergency medicine group that was outside of their network. So it became so common and such an outrage in the lay press that Congress decided to do something about it, and that was the No Surprises Act. And what it does is it protects enrollees who receive emergency care either at an out-of-network facility or from an out-of-network provider. Great. You don't really have time to shop around when you think you're having a heart attack or you've snapped your arm in half. So obviously, American healthcare really doesn't follow normal market rules. So we need protections like this. Another one is when an enrollee uses air ambulance emergency transport services. They probably should have included ground ambulance services as well. AMR is a large company that's backed by private equity, and their costs are rather egregious. Unfortunately, the EMS network in America and the ambulance network is so fragmented that Congress looked at it, said, we can't figure this out at all. We're just going to push it off till later. So it does not cover ground ambulances. And then finally, when an enrollee receives non-emergency care at an in-network facility, but is treated by an out-of-network healthcare provider without knowingly electing that provider or giving consent to be billed. So what's an example of this? This would be like a pregnant woman who goes to a hospital to deliver and gets an epidural from an anesthesiologist who might be out of network because that anesthesiologist works for a PE-backed group. So this is something that is near and dear to my heart because emergency medicine was one of the first fields that was commandeered by private equity groups. So we have large, what are known as contract management groups that are backed by hedge funds and private equity. Envision is the second largest. American Physician Partners was the fourth or fifth largest, and Team Health is probably the largest. Team Health is backed by Blackstone. Envision is based in KKR, who bought them for $10 billion a few years ago. And then American Physician Partners, I'm blanking on who exactly backs them. But one of their business models, and actually their approach to providing emergency medicine care, was not to engage in contract negotiations with any insurance companies, but to remain out of network for all of those insurance companies. And then what they could do is they would receive the out-of-network fee paid by the insurance company, and they could balance bill the patients whatever difference they wanted. That was actually known as the secret sauce for Envision's approach to providing emergency care. With the No Surprises Act, both of these companies have filed for bankruptcy. Envision has restructured and broke into two different arms. One is a ambulatory surgery arm, and the other is a emergency medicine, emergency care arm. American Physician Partners, it's still waiting to be seen exactly what they're going to do. They just entered bankruptcy in September. So what's the solution here? Well, I mean, the obvious solution would be to prohibit corporations from the practice of medicine. And there's currently a lawsuit that's been filed in the state of California by the American Academy of Emergency Medicine, and also ACEP, the American College of Emergency Physicians, has joined in with that as well. It was filed against Envision Physician Services, essentially for being a corporation that practices medicine. Envision tried to get the case thrown out when they went into bankruptcy restructuring. Fortunately, a judge has upheld the case, and the lawsuit is set to begin in January 2024. So we're seeing physicians start to fight back against corporate practice of medicine, looking for the autonomy that I think we all thought we would have when we went into emergency medicine and medicine in general. If it's not obvious, that's why I work for Carillion Clinic. Based on this talk so far, let me know and I'll make it more clear. Right? It's great to work for a nonprofit whose mission is to improve the health of the patients that we serve, as opposed to churn as much money as humanly possible. So really interesting. It's going to be very, very interesting to see what happens with this. I will say that the parties thrown by Team Health, Envision, and all of those other companies have really dropped off now that ACEP is suing them. But that's okay. Small sacrifice to make for the greater good. So we come back to our systems thinking wheel. Obviously, this is how healthcare is delivered. This is commonly known as the hidden curriculum of medical school. And what we've done at VTC SOM is we're putting it front and center and saying that you, as future physicians in America, as physician thought leaders, need to be aware of what's going on in the healthcare system, how healthcare is delivered, and hopefully we're going to provide you with the tools to be change agents and advocates for a better healthcare system, not just people who understand why the system is broken. So with that, we're going to revisit our objectives, and I apologize. I don't think that we necessarily hit these exactly on the head, but I think we've described some of the drivers of cost in the United States healthcare delivery system. We've reviewed some successful approaches from other OECD countries. And we didn't so much devise solutions because so much of this is going on in real time. We've highlighted some of the currently implemented laws that may provide solutions in the future. So like I said, my fellowship training is in clinical research and research design, but I've always been passionate about how we deliver healthcare, why we deliver healthcare the way we do, and how to make this system that we're in better. So some further reading, if you're interested, Dr. Whitmer and I chose The Healing of America by T.R. Reid, which is just a great, quick weekend read if you're interested. It actually follows T.R. Reid, who's a journalist for the Washington Post, who lived in 5 or 6 different countries and had a bum shoulder. And it's his experiences accessing those care systems and how that compared to receiving care in the United States with information filled in. He actually tells a fantastic story about being at one of the largest hospitals in Alberta. It's a large teaching hospital, 500 or 600 beds. Their rev cycle or revenue cycle department is actually 2 women who both work part-time. They have a closet down in the basement, and one of them is solely responsible for billing American tourists who get injured in Canada. So it's a far cry from CASB and our revenue cycle team. I love what you guys do, but our system is broken, and that's why you exist. Most of this information came from Zeke Emanuel's Which Country Has the World's Best Healthcare? It's a much denser version of The Healing of America. It's approximately 600 pages. If you're having a hard time falling asleep, I recommend reading it about how Norway finances their healthcare. And then just some of the kind of more pop culture. Elizabeth Rosenthal wrote An American Sickness, which is a great book looking at how healthcare transitioned into big business. She's currently the editor-in-chief of Kaiser Health News. And then a book that was recommended to me many, many, many years ago when I was a wee baby medical student trying to figure this all out was Your Money or Your Life by David M. Cutler. Other things that you can read are Kaiser Health News. You can follow Dr. Glockenflecken on TikTok or Instagram. He did an exceptional 30-day takedown of the health system in the United States. And every day he proposed a different absurdity of how we provide care. And it's actually both entertaining and educational. So with that, we're at 12:49. So I'll open it up to any questions. And I appreciate all of you taking time to listen to me rant today.
Thank you so much, Dr. Moore. What a super informative presentation. So it's not uncommon for us to see on the news or hear conversations and comparisons about comparisons between the US and other healthcare systems and wonder why we spend so much and still have poor outcomes. This certainly helps us to be a little more informed on the super complex comparisons. But do you have any last thoughts on what we can do or what clinicians can do to help to make the difference?
Yeah, I think from the clinician level, it's just engagement with your with your foundations and your groups and anyone who's advocating for change. And on the patient side, it's advocating for price transparency and shopping around when possible.
Wonderful. Thank you so much. If there are no further questions or comments, please enjoy the rest of your day and stay safe, healthy.
Thank you so much.